My name is Dr. Max Yates, and I'm an academic rheumatologist based in Norwich. I've been asked to give you a talk about three main points. And really what I'd like to cover are the etiology of polymyalgia rheumatica, which is largely unknown. Secondly, I'd like to talk to you about the incidence and how estimates for incidence vary around the world. And then finally, I'd like to talk to you about steroid usage, and particularly from administrative observational data sets. So first of all, if we take the etiology of polymyalgia rheumatica, as I said, it's largely unknown. We know that it generally affects people of older age, and typically it's said that those in their 70s are at greatest risk. Actually, if you look at the estimates that have been published, the age-adjusted incidence by 10-year age band continues to go up, even in people in their 80s and 90s. However, it is true to say that the majority of people are diagnosed in their 70s. This is largely reflective of the demographic structure of many countries, with an older population within their 70s than within their 90s, obviously to do with life expectancy. Now, there have been some genetic studies looking at polymyalgia rheumatica, and some investigators have also tried looking at genome-wide association studies. And really, there's not been a consistent story. And sometimes people have argued that this may be due to case selection. So perhaps we've not managed to capture a pure pool of patients with polymyalgia rheumatica, and this has then led to lack of an association being displayed. The other thing is that people have looked at kind of lifestyle factors or environmental factors, and again, these are kind of inconsistent. However, there does seem to be a strong correlation with age, and women are more affected than men. Of the genetic studies, HLA and PTMP22, these sorts of things have been purported as showing some signals of significance. Now, turning to incidence, the highest incidence is within Western Europe, and particularly more northerly latitudes, Norway, Sweden, for example. And if you take those countries, then the incidence in those aged over 50 can be as high as 1 in 1,000, perhaps even 1 in 800. And particularly if you then move to people in their 70s, or 1 in 500, 1 in 300 people. If you then reflect that to the United States, overall, for people aged 50 or above, the estimate is around 1 in 1,500 people. But if you then look to other places around the world, there was a recent study in Buenos Aires, and they had about a rate of 1 in 1,200, so similar to the United States. And then you take somewhere like Korea, where it's actually 1 in 50,000. So there does seem to be, variation around the world. Now, we can either accept that as truth. We can think that maybe it's just chance findings, which seems a little bit unlikely given the fact that studies have consistently reported a high incidence in Europe and North America. Or we can consider that there's some sort of bias. So the way how these studies have been constructed, it's important to look at how they've defined the disease or how they've captured their population in the first place. So obviously studies that are from GP databases, in America you would call that family practitioners, those treated in the community, well, then you're probably going to end up with a greater capture of people. It's more likely that those criteria are going to be sensitive, so that you'll capture everyone who has disease. But it may be that not all of those individuals will reach classification criteria sets. So typically, those studies that report on case classification criteria set validation will report a lower disease estimate. Finally, if you look at steroids, that does vary, but there was a meta-analysis published a couple of years ago which shows a surprising degree of correlation and consistency in terms of the duration of steroid use. So whether people are starting at 15 or 20 milligrams of prednisone, but if you look at then the continuation of their treatment, around 50% of people will be on steroids for longer than 2 years. If you take that out to 3 years, there's still a third of people left, and by the time you get out to 4 years, a quarter of people left, and it's those individuals that are then likely to be left on long-term steroids. So as a community, as practitioners, as doctors, we really need to think about how we best target any new drugs that come available to us to try and reduce the steroid burden and ultimately reduce those number of individuals who are left on long-term steroids. So John, that's really what I wanted to talk to you about. And if anyone has any further questions, then please look me up on Twitter or have a Google search, find my work profile page, and I'll be happy to answer any email queries that you have. Thanks very much.